morning. Welcome. Thank you for coming to Primary Children's Pediatric Grand Rounds and this is the annual Pediatric Otolaryngology lecture. I am Dr. Miguel Canacal, the Pediatric Hospitalist and Course Director. Today, the Cloud CME claim credit code is 33048 for everybody to claim. The online questions go in the live chat, and for those in the auditorium, if you just raise your hand at the end, we unmute the overhead microphones and the speaker can just call on you and doesn't have to repeat the question. Please nominate a safety hero if you see a zero harm technique being used or somebody who prevented an error. So this one, a safety moment that we do, listen for the technique of stop and resolve and ARC. That's the one on the end. The ask a question, raise a concern, or chain of command. So we did an emergent airway on University of Utah NICU. And after the case, when the tracheostomy was secured and we had the baby in the transport warmer, right during the time when the techs were usually would be busy breaking down the tables, a surgical tech was still keeping an eye on the patient before leaving the room. And he noticed and spoke up the baby's head looked purple, more purple than when we had received the baby because already kind of red and bruised from being born. But it turned out that the trach collar was too tight, and so this was fixed and they prevented a potential safety event. So we appreciate every single member of the team, of all the teams we have, speaking up for safety. And now Dr. Albert Park from Pediatric Otolaryngology will introduce our speaker. Switch to the presentation.
Good morning, everybody. My name is Albert Park. I'm Division Chief of Pediatric Otolaryngology here at the University of Utah. I want to personally thank Dr. Canacal for his collaboration on these grand rounds that are jointly supported by Otolaryngology and the Department of Pediatrics. This is a joint effort in which we choose a leader who really bridges both fields in a very impactful way, and I think we're really in for a treat with Dr. Glenn Green here. Dr. Green is professor at the University of Michigan. He's one of that rare species where he's an outstanding surgeon as well as an innovator and researcher. Maybe even rarer, he's also has bridged the spheres of academia as well as an industry. And so he's been truly impactful. And one example, which I'm sure he'll go into more detail, is that his team has been the first to successfully place an airway stent for an infant with life-threatening bronchomalacia under an FDA provision for emergency use. And he has numerous accolades, including a innovation award from Popular, I think it was Popular Mechanics, as well as he's been an invited speaker for TED Talk. So again, without further delay, really glad to have Glenn here to give this presentation.
It's a great pleasure to be able to meet with you all and talk. I realize most of the people are online, and this is really fun for me. The last time I was at Primary Children's Hospital was 35 years ago as a medical student when I came here to do an away rotation with John Carey, who was nice enough to come here. I was interested in the genetics of rare diseases, and that's the first time I saw a child with trisomy 18. And so we've been doing some really interesting work together on trisomy 18, and I was just telling him that we'd just had our first trisomy 18 clinic. And so I've been working on how to help these kids that have super complex airways and what we can do to try to help these kids. And as a shout out, he's going to be talking about what Primary Children's is doing on December 12th. So that's, I'm going to go in and intrude on your lecture at that time. Today I'm going to talk about some of the things that we've tried to do to help kids with a variety of airway problems, as well as talk about the ways that we've used 3D printing from an educational standpoint. So I've got a number of conflicts here. I'll be discussing devices that are not FDA approved. We just had FDA approval to begin a clinical trial, and the University of Utah will be one of the sites for that. So I'll be talking a little bit about the entrance criteria, for that. And so the pediatricians are going to be the people that actually see these patients more than anyone else. I have patents related to several of the devices that I'll be talking about, and one has been licensed to Materialize. The Splint has been licensed to Materialize, which is a Belgian medical 3D printing company, and I formed my own company, Make Medical, for medical devices and medical modeling. I also have a number of grants and supports from a number of different places, NIH, private donations, Apple, and internal grants as well. I was talking, one of the hardest things is how do you get support to do some of this research? And on the drive over here, it's like, okay, how do you get support when you've got an idea? And how do we support the residents in their own ideas in helping them develop things? And so a lot of it, the thing that's really nice about 3D printing is it's relatively inexpensive. So you can try things out and go through rapid iterations to find something that works and then try to get additional funding. And it's one of the few areas that I found that you can kind of start from scratch and then develop a program around. So we've received a number of accolades. This is from President Obama's State of the Union address. New workers are mastering the 3D printing that has the potential to revolutionize the way we make almost everything. And I won an award from President Obama and went to the White House and had all the security clearance to get in there. And but there were budget negotiations, political things, and so he wasn't able to actually give me the award at the last minute. So that just shows how politics enters into everything. And so I'm going to risk showing this next slide here of another president that talked about 3D printing. And this is President Trump at his foreign policy initiative when he was president. We need to think smarter about areas where technological superiority, and nobody comes close, gives us an edge. This includes 3D printing, artificial intelligence, and cyber warfare. So these are nice things to be compared against, artificial intelligence and cyber warfare. So the basis of 3D printing, Michigan has some strength in this. It originally came from the auto industry, which Detroit is really strong in. And University of Michigan in particular has a bunch of tie-ins. And so we've had 3D printing and used medical 3D printing for quite some time related to initial support from the auto industry. And the initial thing that's needed is imaging. So one of the things that I did was I got a CAT scan of a fine resolution CAT scan of myself. And so you can see that you can separate different tissues, bone and airway and soft tissue, and then you can take this, bring it to a 3D printer and make objects that are nice images of what the initial object was. And so I was able to see what my own skeleton looks like. And then you can do some fun things with this. So this is a silicone mold based on my soft tissue that was placed over a bony 3D printed skeleton of myself. And I did a face swap here. So this with an app. Okay, here at the University of Michigan lab, we're doing a lot of fun things. Go blue. So we use this mask. This has been used to help with CPAP fitting, to teach people how to do CPAP fittings. So there's extremely fine resolution. So this is a temporal bone, and you can see the level of precision that you can get with 3D printing. So a dime, and this is the malleus here for comparison. So the limitation of 3D printing is the quality of the imaging rather than the ability of the 3D printer to make things. So extremely fine resolution of things. We're able to do very complex geometries, manufacture complex geometries in ways that can't be done otherwise. And so this right here is my larynx. We made modifications to my larynx and put a grill into the side, attach a Bluetooth speaker to my larynx. Then we took a pig and excised the larynx from the pig and then implanted my 3D printed larynx into the pig. So pigs, just like neonates, they breathe through their nose. And so in order to have the pig be able to have phonation out of its mouth, we excise the soft palate of the pig so that the noise would come out its mouth. So this is Hamlet, which is a pig that has my larynx that's 3D printed inside of it and controlled with a Bluetooth speaker. We're able to do extremely complicated things across multiple areas. And so there's a 3D printer and a space station. So you can you can send digital plans to make something. And the Department of Defense was interested in what we were doing because you can have one of these in a submarine and make parts inside of a submarine. One of the projects that we did was working with Nepal, which is one of the poorest countries where it's hard to get medical supplies, and they're really dependent upon donations of outdated equipment. And then when that equipment breaks down, then there's no way to get parts to go and refurbish that equipment. And so we brought a 3D printer up into one of the rural hospitals in Nepal, and we're able to make the plans in Ann Arbor so they can print it locally and refurbish their own equipment. So this is a really nice thing that allows people to be more independent and better able to use the charitable contributions that they've already gotten. As another project that we did, this was in Saudi Arabia. So we were able to get a CAT scan that was done locally, have that sent to Ann Arbor, and make designs there sent to a 3D printer in another place. So you can have transcontinental things done because this can all be done over the internet. Now, I've talked I'll talk a little bit about regulatory things. And this was the least regulatory difficulty that we had. We were doing this project for the King of Saudi Arabia. I found that if you work for a monarch, then all the regulatory burdens are not there, and they can do whatever they want, almost. So one of the things that we found is we were going to bring a 3D printer and put that in the palace in Saudi Arabia, but it turns out that the 3D printer was made in Israel, and if you have something made in Israel, then you can't bring it into the palace at all. So there's these complex geopolitical considerations that I never conceived of even possibly being involved in when I was a medical resident. I want to talk a little bit about what happened during COVID as an illustration of some of the rapid pivoting that can happen. When this happened, we made a big change in what we were manufacturing and what we were working on. We made 11,000 face shields for people, made nasopharyngeal swabs, ventilator multipliers, and our residents weren't able to operate. And so we made a bunch of teaching models during this time so they could continue to work on their surgical skills during COVID. And so this is early on. Michigan was hit very early on, and there is really a big concern for shortage of ventilators. And so we came up with the method for taking one ventilator and using it to ventilate 2 patients. And so you can see this was on the 19th, we had the plan. We were able to make a virtual construct of what we wanted to print and then 3D print it. So we're able to try multiple iterations of this and have something within a couple weeks. Then and this is a more complicated device that we made for pressure regulation. And so we were able to get a device within 1 week. We had the 3D printed, and then bring this to a manufacturer for more mass manufacturing purposes. And we had a milled production of something that would work within 1 month of initial conception. And then we got FDA emergency US authorization for this to be used. We found out that there really wasn't a shortage of ventilators in the US. We worked with the World Health Organization and the United Nations to help in other countries. This is working with animals, showing that you can ventilate different types of animals at the same time. So we had a sheep and a pig, so totally different physiologies. You'll notice, you may notice a little blue thing right here, and this creates PEEP. And just as a way of talking about regulatory things, this was made pre-1976. So anything that's before 1976 doesn't require any regulatory burden. You just need to have good manufacturing. So you don't need to go through FDA approval. And so we were trying to figure out how could we develop something that would create PEEP. We found this device that had been used about 50 years ago. We then found we had to go and find where it had previously been manufactured. And so we were looking up this old name that no longer existed for a company, called the company up, and it was during COVID when nobody was around, but the president happened to be in the office. The president, when he was an intern, remembered working on it and knew where the old blueprints were. So we were able to pull those old blueprints out, create a manufacturing facility, and make hundreds of these with FDA approval because it was pre-1976 and was grandfathered in. And this is some work that we were showing that we can operate on a pig. So we can actually do an operation on one animal while another animal is being ventilated. So the images that can be used for this can be a variety of different images for 3D printing. This is from ultrasound and MRI. So we were trying to decide, would we need to do an exit procedure on this child? And so we saw this mass. We're like, okay, is this a cleft lip and palate, lymphovascular malformation, or an epignathes? We then were able to go and print from the image. And so you can see that the image that we're able to print was fairly similar to what the child had, and it gave us an idea of what we need to do as far as intervention into the airway. And so this child was actually not born with an exit. We said, this is an airway that we can get to. And so, but we were able to innovate. And I was talking to the people here, and it sounds like every other month ENT will be on standby for an intubation. And so we found that this can be helpful for visualizing things. And as a more complex, and this is him after repair, it's a more complex case that we did with similar visualization being extremely helpful for these conjoined twins. So with conjoined twins, you need to have two delivery teams, two teams to manage the ventilators, two teams with one team involved for each person. And so being able to do a dry run, and okay, here's when the child's born, when these children are born, here's how they're positioned relative to each other. What will we need to do to be able to intubate each one? What is the relationship between the kids? And in this case, having a handheld model helped us appreciate the relationships, but we also had a life-size model that we were able to make as well to actually practice the delivery and have dry runs. So this is something that has turned out to be extremely helpful for us when we're taking care of conjoined twins. This shows the splint and the laser sintering that we use. This is my favorite video. A team from Japan came and filmed this, and this is my favorite depiction.
研究所にある大型の 3D プリンター。特殊な樹脂を使い、立体的な医療部品を作り出すことができます。厚さわずか80ミクロンの薄い樹脂の層に上からレーザー光線を当てることでコンピューターで設計された形を焼き付けて固めていきます。それを繰り返し積み重ねることで複雑なデザインでも数時間で完成させることができるのです。
One of the things that we did early on was make a 3D printed tumor. So there's a boy that wanted to go and smash his tumor after it had been cured. And so he called his tumor Boris. And so we made, I actually used my home printer for this and then added some blood vessels over the top with some paint and then filled it with applesauce that was miscolored. So they would be able to smash this and have it go all over the room. And so we said, oh, this is going to be a great thing to do. We'll provide this service for anybody that wants to smash their tumor, and no one was interested. So we have these, just because you have an idea that you think is good and is going to work out, I'm going to be talking about a lot of things that have worked out here, but most of my ideas have not worked out at all. This is a surgical model that we've used for a child that had a juvenile angiofibroma, nasopharyngeal angiofibroma, or JNA. So if you see particularly a young man that has epistaxis that is severe and recurrent, then it's very important to go and look in their nose and make sure that there's not a tumor causing that. We'll see probably a half dozen of these a year with our referral base. And I don't know, how many JNAs do you see a year here? Yeah, so the same number. And these, the earlier that you can identify them, the easier it is to get them out. And so this was one that was complex, and we said, okay, we can't tell if we're going to need to do something more open or not to resect it. And so we made a model of it in the tumor, and we practiced a surgical approach to see if we could get this out endoscopically. When I was initially in my training, we'd do all of these open and do Lefort osteotomies to open these up. And you'll remember those days. That's the big operations needed to get them out. And a lot of these can be done endoscopically, but when you see them kind of trailing off to the side, it gets a lot trickier. And so I'll show you how so talking to the family ahead of time with the tumor. And this is intraoperative pictures comparing the surgery, the virtual surgery here, compared to an actual intraoperative picture of the surgery, and then the tumor after resection versus the 3D printed tumor. So we're able to get pretty accurate depictions. There's things that are different. When you're operating with the model, there's no blood loss at all, which is super nice. And the other thing is you can make multiple models. You can try different approaches and see what works and what doesn't work. And so it can make it a lot faster when you're actually in the operating room. One of the things that we've done is make a bunch of models to go and teach people how to manage different problems. So we have a otolaryngology boot camp, as well as a pediatric otolaryngology fellowship training module. And so we'll teach people around the country how to do different operations. And so it's a chance to do a lateral canthotomy or drain hematomas. We've brought these also. One of the things that I'm proud of that we've been able to do is bring cleft lip simulators to a lot of foreign countries, where we'll go on a mission, help repair the clefts, and then leave a bunch of simulators behind so that the people can keep their skills up, hopefully, and be able to provide that ongoing surgical support locally without needing us to be involved. Our goal is to have independence for the local surgeon. And as last night we were talking at dinner about different proud moments that we've had, and hearing how a local hospital was able to go and develop a gigantic core of surgeons and do, was like 1,000 operations a year? Yeah, so 500 cases a year locally without needing us to go there every time. This is a really great thing to be able to do. We've made teaching modules. These have been very helpful. When I was a medical student and resident, we learned to do nasal laryngoscopy by practicing on each other. And as we've taught some of the pediatricians how to do this, and some of our residents and students now, we found that models are a nice way to get comfortable with things before they're actually doing the procedures on patients themselves. And so this has been, our pulmonologists and allergists are doing a lot of nasolaryngoscopy now. I think I heard that some of the adults are starting to do that here, but it's something that we've been working on, trying to teach people how to do some of these procedures. This is an airway model of stenosis where we can practice operations beforehand. This is endoscopy showing the stenosis and what the trachea looks like. It's blunt-ended. Instead of having a carina here, we didn't build the whole lungs out. We have a different model that we've made actually it was made for the pulmonologists at their request for them to be trained in bronchoscopy, for cleaning out pus in different areas and learning how to do bronchoscopy in kids. It's very easy to change the sizes of things so we can have people practice from a neonatal airway to an adult size airway, and you can create malacia and different things in the model as well for people to identify. So it's a good way of giving people a lot of experience relatively quickly. This is a practicing surgery, and so we can see how different residents have done before, how they're going to do their LTR before they actually carve it. So we'll take rib to carve this, and so if the rib is miscarved, then you need to go back and take another rib. And so it's really, normally we're pretty scared about doing that. We'll manage it ourselves, but if you have a student, really not a student, but a resident doing a nice job beforehand, then you can give them a lot more freedom than they otherwise would have. And it really has helped our fellows. And you can see, okay, you know, maybe this resident, we don't want to have carving our grafts yet. And so this is a boy with Treacher-Collins syndrome who had obstructive sleep apnea. His mother was, you can see how he doesn't have a tracheostomy at this point, but he still had a lot of obstruction, so he was dependent upon CPAP. His mother was waking him up every hour to go and adjust the mask that was having trouble fitting. So in this case, we use a digital photography to create the image. And then from this, we were able to create a custom interface with a regular CPAP mask. And so this will show the process here. And you'll see, because it is just digital photography, it's just superficial. There's nothing beyond it. And this is the interface that we made that matches his face. And then with the traditional CPAP mask. And so this is a picture of Tyler, and then the picture, the 3D visualization, the 3D photography of his face, where we wanted the mask to fit. Then we took the negative, made a mold of the negative of what we wanted the interface to be. We brought that digital design into a 3D printer, printed it, then cast the silicone, took the silicone and put it in with the mask. And then we were able to use this in the operating room and for his use at home. So he was able to get much better sleep and have this work. We ran a large trial of, I shouldn't say a large, a small, we had a nice bucket funded trial to make these masks, and we're successful with it. But the amount of engineering and work that it takes to design these makes it not cost effective to make these, unfortunately. Another thing that we've done is for individuals that just depend upon the tracheostomy for nighttime use, we've designed a plug to use during the day so they don't need to have the trach ties. This plug can be customized. It goes in through the stoma. You can make decorations or make it to look like jewelry. And so this ended up being very nice for kids that have congenital hypoventilation syndrome that only need their tracheostomy at night. And so something that I didn't appreciate about this, I thought, oh, it'd be nice to have this, but it makes it so you can wear a necktie for prom and wear things you otherwise wouldn't be able to wear with the tracheostomy. So it's some real nice lifestyle things that we're able to do with these. And this is, it's used in cancer patients, comparing what the button looks like to what the tracheostomy would normally look like. And then this doesn't have the decorations, and you can also match the skin tone with this. And this is an endoscopic view of what the trach plug looks like. So this, I'd like to talk a little bit about tracheobronchomalacia and what we've been doing for that. This is Marcus Aurelius, and for the Romans, the definition of being alive was being able to breathe. That's what determined whether or not you were alive or dead. We saw this is in Italy. I got to see the actual statue, and this is almost the only statue of a Roman emperor. The Christians went and destroyed all the statues of the Roman emperors, but they thought this originally was an apostle, so that's why this one statue survived. So these are kids that have tracheobronchomalacia, so it can vary from relatively mild to severe. This is a boy, this is how he spent Halloween, trick-or-treating from his bed. He's got a bag right above his head for if he has an episodes and needs to be bag ventilated. This is the second child that we did from the University of Utah, demonstrating the complexity and the number of drips that are put on the kids. And so these kids are often needing to be paralyzed. And of our series, 2/3 of the kids had been paralyzed and coded and had a variety of severe medical problems, often never being able to leave the hospital. Most of the kids had never left the hospital their entire lives. So which kind kids get the tracheobronchomalacia? Kids that have prematurity or predisposed to having it. Kids that have prematurity are a lot more likely to have distal malacia. And so if somebody has a tracheostomy or is endotracheally intubated, the easiest way to treat the tracheobronchomalacia is with positive pressure or a CPAP titration, where they'll do a bronchoscopy and see how much pressure is needed to hold that open. Traditionally, would use a ventilator to support this. And if they are a premature kid that has distal disease, that's still our recommendation universally, is for tracheostomy vent dependence. And so a lot of kids with trisomy 18, for example, will have severe malacia. And if you do a CPAP titration, then you can just give positive pressure, hold that airway open. And we went from 10% 1-year survival to over 80% 1-year survival by aggressively managing the airway. It's more common in Black patients for unclear reasons and somewhat associated with prematurity. The other thing that I wanted to mention is just kind of a side here related to our Apple research project, was that we're looking at sound exposure in different populations based on what we get from iPod use. So we've got millions of data points. And so one of the things that we've noticed is that the socioeconomically disadvantaged people will have more hearing loss with the same noise exposure. And that's presumably due to being in an environment where there's more toxins in the air. The poorer environments or poorer populations are more likely to be in places where there's more factories and other things that we know, for example, cigarette smoking can impact hearing loss. And so there's a demographic aspect to a lot of the things that we do here. From a physiology standpoint, one of the key things that this is just to remind the residents and people that it's radius to the 4th power. And so when a small change in the radius can make a gigantic difference in the amount of resistance that occurs. And so as a general rule, with people that have tracheobronchomalacia, if you can let the kids grow, then the problem will go away. So how do we get the kids to survive for the first couple of years? If they can survive through that time, then they don't need support for the airway. Another thing that happens with tracheobronchomalacia is that there is a pressure drop that happens when you're going through an area that's small, and that will cause further collapse. And so if you can open this up, you can decrease the amount of pressure differential that's happening. And so the whole goal, one of our goals in treating tracheobronchomalacia was to find a way to keep the airway open so that the child can grow and the disease would resolve by itself. So this is an example of tracheobronchomalacia where we see complete obstruction on one side. You may have noticed that distally, this area is very expanded. So you get post-obstructive bronchiectasis and malacia distally. One of the ways that people have tried is to put an internal stent in place. If you put these in, you can see horrible amounts of granulation tissue that can occur. And so these are actually contraindicated at this point. Trying to remove these is extremely difficult. You basically have to grab them endoscopically, pull as hard as you can, and then try to manage any bleeding and pneumothorax and all the other problems that occurs afterward. Very high mortality just trying to remove these. So we developed a device that goes around the outside of the airway. It's designed to open up over time to allow for growth and support it and keep it open. We used a printer and polycaprolactone to manufacture the splints, so they'll dissolve after about 4 years. They can be customized to the patient's specific defect. They provide support against external radial compression, allow for growth and expansion, and they're placed externally so they do not affect the mucociliary architecture. When we did finite element analysis to look where the pressure was, and so we made sure that there would not be a lot of pressure anteriorly where there'd be blood vessels that we're supporting. There's more pressure posteriorly, and our concern was erosion anteriorly. We placed splints against the carotid artery and jugular vein in a pig and verified that there was no erosion. One thing that we did not appreciate at the time was that you can see how there's increased pressure posteriorly. We didn't think this would be a problem, but about 10% of kids will get erosion into the esophagus posteriorly with the splint. So we will now go and put fascia around this posterior part to try to prevent that from happening. But so this just shows that you think you've figured out the problem, know what the greatest risks are, design things to prevent it, and still unexpected risks. And when you go to put these in a child for the first time, then you have no idea what to even expect. And so there's the first people that had this done were very much pioneers and parents who were really willing to do things where there were a lot of unknowns. There weren't alternatives, it's really taking a lot of risk with their child, and it provides us a lot of information for the future as well. This is mechanical testing of the splint. When looking for animals that have tracheobronchomalacia, it ends up that really cute dogs are the only things that have tracheomalacia and miniature horses. So this was not a good animal model for us to use, but we have done some work with the veterinarians. This is tracheomalacia in a dog here. And we went to a pig model. And so the pulmonologists will talk about a bronchus suis a lot. That's where the right main stem comes off. And so this is an actual pig. This is a pig trachea, and this is an actual bronchus suis in a pig here with the right upper lobe coming off higher. So, and this is what it looks like endoscopically in a human when we talk about bronchus suis, normally lower and closer to the carina. The other thing that we found, normally we talk about the posterior membranous wall and a C-shaped ring anteriorly, but in the pig, it actually curls on itself, and so the cartilage will actually overlap in a spiral type configuration. So there's anatomic differences that a lot of times we don't expect will be there. And so when we use, and this is present in a lot of models that had been used to test tracheomalacia before. When we tested them, we said these models, all the models that people had published on before, are completely inadequate for demonstrating severe disease. So we had to go and make our own model. So we did make our own model by excising the cartilage and creating a malacia model. These are some of the pigs that had splints put on. So these 3 pigs had splints put on. These are pigs, the control animals. One of the control animals has already died. The control animals had the classic signs of tracheobronchomalacia. So they get, it's a little bit hard to see here, but the snout is blue. They have low energy and are lying down, and they have retraction. So very similar to the humans with it. We looked at growth over time and showed that in the pig there's nice growth. So for humans, to place these, it's standard median sternotomy. Pulmonary bypass does not necessarily need to be used. Most of the kids will have an accompanying cardiac, congenital cardiac disease that needs to be repaired, and so bypass makes it easier to put the splints on. For the dissection, it's a 270-degree circumferential dissection, and we try to preserve some of the vascular plexus, but that's not necessary to do. There's enough that comes from above and below to supply the area. Bronchoscopy can be used to determine and verify that things are opening up with this. We use a valve suture guide to organize the sutures and then parachute it down to the trachea. So this is a virtual design, and this is just a model of how the device will fit onto the area that has the malacia. And an actual implant in a child. This shows the airway open after placement of the splint. And so you can do a variety of different things with the 3D printer depending on how the specific defects are. And then this shows the changes in the blood gases that occurred afterward. So preoperatively, this shows this profound metabolic alkalosis compensating for the respiratory acidosis, and the patient is still acidotic at 7.3 pH, despite the alkalosis here. It took immediately there was improvement in the pH, but it took about 3 months to see full normalization of the blood gases. We also saw growth 1.4 millimeters, cubic millimeters in size of the main stem bronchus, left versus 3.2 on the right. Post-op, they were the same. And after 3 months, there was actually greater growth on the side with the splint than on the side without the splint. And this shows how it often will take several days or months to discontinue the ventilator afterward. And so this is a second patient. Actually, because the pressures to ventilate this patient were so high, this is a patient from Utah. He was getting recurrent albumin infusions and immunoglobulin infusions related to a protein-losing enteropathy. And so this was one of the diagnoses that he had. And one of the things that's nice is that after we put on the splint, we were able to drop the pressures, and the hypoalbuminemia and the immunoglobulin deficiency actually both went away by decreasing the pressure. So this was really nice, and it actually gave us some insight on the effect of high pressure on some of these diseases. This is growth over time. And so we've now put in nearly 100 splints in 50 patients. We have had about 15% of the kids have died. One of the cases was due to the splint. We've got an exclusion criteria where we will not do some of the things that some of the critically ill kids, we will not implant them at this point. So we have an 8-year trial. Subjects will be followed for 5 years. It's 35 subjects and 60 splints, and the University of Utah is one of the sites. This is the inclusion criteria to have a corrected gestational age of 1 week to up to 4 years of age clinically. We can implant outside of this, but this is for the trial. They need to have clinically significant tracheobronchomalacia where they're unable to wean off mechanical ventilation, they're dependent on a tracheostomy, or they meet the indications for getting a tracheostomy. Their life expectancy needs to be greater than 2 years, exclusive of the tracheobronchial malacia, and they need to be reliable for follow-up and getting consents. Exclusions are single lung or single ventricle physiology. This was responsible for 4 of the deaths that occurred. A fixed stenosis won't be helped by an external scaffold, and diseases of the cartilage itself will not grow over time, where the cartilage itself is too weak rather than compression or abnormal formation of the cartilage. And if there's posterior wall intrusion, then we found that laser tracheobronchoplasty or a posterior suspension are much more appropriate than placing an anterior device for this. So the endpoints for this are survival is a primary endpoint and airway patency, but we're also looking at quality of life for the patients with infant and peds generic cores and a family impact module, device-related complications, and then length of stay in the hospital, days of hospitalization afterwards, time to vent discontinuation and decannulation, and time to discharge home. So one of the latest things that we've been working on is tracheal agenesis. This was universally lethal before, where I had a child that came in and the family agreed to have a post. So we went and dissected this all out, verified, developed a reconstructive mechanism for this. And then we had a child that was born. We bring the esophagus out the neck and intubate the esophagus. The bronchi or the esophagus and the stomach are separated, and a feeding tube is put in. And so we're able to ventilate through the esophagus that forms in neotrachea. And then spit is kept separate. And so this is an external scaffold that's placed. This is actually the esophagus with the bronchi coming off the esophagus for a kid with tracheal agenesis here. So you can see that there's no collapse and it's held open. This is a child with tracheal agenesis.
Thank you. There you go. How about all done?
So you can see one tube coming out of his neck. This is where all the spit will go out, and the tracheostomy that's going into the esophagus. Later on, the stomach is connected to the mouth, and the spit fistula is taken down. Right now, we're designing an operation to connect the larynx to the neotrachea to allow the child to talk. That operation has never been done anywhere yet, and we're designing that operation at present. And then as far as another future direction, this is, we're working on taking the same constructs, adding stem cells to be able to create cartilage as from scratch. This would be for kids that have microtia or problems with their nose and traumatic defects. Then here is one of our mice with here, the polycaprolactone does not resorb over time, and so this has good long-term patency. There's nothing that's stopping us, and we're talking with the FDA now about getting approval to go and use this device in helping kids. So these are some of the children that had tracheobronchial malacia and early on, and this is Garrett, who is now 12 years old, and that was a patient that was referred to us. So this is dependent upon a large number of people and funding. Scott Hollister is a bioengineer that helped develop this. He's at Georgia Tech now. Dave Zoff is a brilliant person that was in my lab. He just moved to the University of Wisconsin. And Kyle Vancouvering is now at Ohio State. Just some of my trainees that are doing outstanding things in their own right. And so I'll close with a quote from Marcus Aurelius. When you arise in the morning, think what a beautiful gift it is to be alive, to think, to breathe, to enjoy, and to love. Thank you.
Thank you. What questions do we have?
Hey, Dr. Green, I have a couple questions, but I can not dominate. The main one was we have like you mentioned earlier that the quality of your models is dependent on your imaging. We've got, over the years, they've hired like a really amazing like cross-sectional team for the cardiac service. And so they're doing a lot of 4D CTs and virtual bronchoscopies, which are amazing. And they're in real time with beating heart. And so you can actually see like great vessel compression on the trachea virtually from within the, but I have a question. One, are you guys doing that? And then two, how good is CT at discriminating complete tracheal rings? Because it looked like a lot of your tracheal reconstructions were from like a CT DICOM set, but we've had this debate here whether CT is adequate enough to identify complete tracheal rings, and do we need a bronchoscopy from ENT in that setting?
Yeah, so the short answer is bronchoscopy is the gold standard. And anything that you do based on CT is subject to a variety of inaccuracies that can happen. And so I'm very hesitant about using virtual bronchoscopy. So I find it useful in some cases for like, okay, is there a foreign body or not? In some situations it can be helpful, but still it's really cases where you can't do the bronchoscopy for some reason that you want to do that. And so when are you not able to do the bronchoscopy? If with the tracheal stenosis patients, sometimes it's so narrowed. So we've had kids that were born that had 2-millimeter airways that as neonates, and it's like we can't do anything with this kid at all. And so you put them in the NICU, you hope they don't die, you have ECMO ready all the time. If they have something happen, you don't let anybody that is even exposed to any illness go in and have them on maximum precautions so they don't get a viral illness and get any swelling. And then hopefully they grow big enough to get bigger, that you can do the repair. So if you've got an airway that's super narrow, where you can't see distal to it, and especially looking at stenoses that go into the main stem bronchi, then CAT scan becomes super helpful for identifying where those issues are. One of the things that's really common is that we found is that secretions will make it so the airway appears smaller than it really is. And so when we run through the protocol, we say that you need to have bronchoscopy before our CAT scans to suction out the secretions so we don't have secretions giving us an incorrect idea of whether or not there's narrowing of the airway. Then endoscopy, I think, telling on a CT whether there's something, so sometimes the rings will look like 90% when you're doing endoscopy, but you can still see a membranous wall posteriorly. In a CAT scan, you can't identify that there's still that membranous wall, but surgically, it's really important to know where the actual stenosis is. So, I'm really hesitant to do, it's fun, it's a fun thing to do virtual bronchoscopy, but I wouldn't recommend it for most cases. But there's certainly some areas where you can't do bronchoscopy for a variety of reasons where it can be helpful.
Way to collaborate with radiology to try to find ways to optimize what CT shows versus bronchoscopy, because the thing that I've found, like we have ENT bronch for all our airway cases that we do together, or vascular rings, but one thing that they can't tell you is where the compressions, they can tell you like, is it coming from anterior or lateral, but they can't tell you like what's actually happening in a cardiac cycle, which is what the 4D CT really gives you. But Jeremy and I had a slide tracheoplasty and the airway was like micro, and we got in there to do the slide tracheoplasty, and we actually had a pretty normal sized trachea just with luminal stenosis. And so the CT way overestimated like how severely narrowed the trachea was, and we were able to do the slide pretty well.
Yeah.
So I feel like those two modalities could be really complementary. We just haven't like sat down and tried to do that.
Exactly. And so one of the problems that we have in the trial is we need to have some estimate of is the airway more open or not. We've just talked about how the CAT scan is inaccurate in all these ways, but it's hard to have an accurate estimation as far as percentage-wise from visualizing the airway. So that's where we're weaker. It's harder. A human can't do a good job with our eyes of distinguishing 45 from 65% narrowing. So it gives us and it also gives us an objective number that we can look at to compare.
Got access to you. I want to ask you a question. That Utah patient, I actually came and hung out with you and Rick when you did that, because that was a patient I had operated on. One thing I was like a little surprised about, like I think the splints are amazing, which is why we wanted to be a site, but there, as material like engineers with time, do you see the profile of the splint becoming, with new products, smaller? Because it seems like it's a little bit of a, like a little bit of a
thinner.
bulky, yeah, like it's a little bit of a bulky product, and especially if you're putting them on both bronchuses, main stem bronchi, in a kid that's only like, you know, a couple weeks or a month old. Like, do you see the product like evolving over time, or do you feel like this is kind of the end product?
So that's a great question, and there's a couple things that enter into that. So one is the limitation on bioprinting and having structural strength. And so there's a limit on the thinness that the splint can be and still have adequate strength with mechanical testing. The second is, once you get something FDA approved, the process for getting it changed, it's a lot simpler than doing it the first time, but it's a pretty involved process. And so personally, there's a bunch of changes that I think would be nice. We've got something that works that we want to get the FDA, it's already been a decade. And so we're just trying to get it approved. And that's been very difficult in a lot of ways to get to this point. But there are things that can definitely be done to be further improvements. And so we expect that that'll happen later. But some of it is just technological and material limitations, and then some of it is regulatory related.
From online questions, most of them are about how about this body part, how about that body part, but we're asking about ribs for thoracic insufficiency. Is anyone working on that? And then a place for the 3D models in cases of esophageal atresia.
So we can make models of anything, and so yeah, so we made models to, in fact, for the tracheobronchial malacia, we make models so people can practice doing the operation beforehand. So we've done some cases internationally, and that's extremely helpful to have people practice on those beforehand before doing a case. Here, we're going to send a surgeon to proctor the initial cases. It's for a very talented surgeon, it's relatively straightforward, but it's still a new operation. And the idea is really pretty simple. And my best ideas have been simple things that are kind of obvious in retrospect. So let's see and then thoracic. So yes, we can make a model for tracheal agenesis to go and practice surgery on beforehand. And if a patient like that's born here, so the thing that's unusual is that normally when you see a tube in the esophagus, in fact, that's what happened with our cases, is the tube's in the esophagus and the kid's doing well with good oxygenation. You say, oh, the tube's in the esophagus, we need to put it in the trachea. You can't put it in the trachea, and then the kid's desaturating without it in the esophagus. And then you notice that everything's okay. You go to the operating room to put a tracheostomy in, and there's no trachea. And so that's the first time I saw that, it was just shocking to not see a trachea there. Then thoracic insufficiency, that's a tough problem. And so there are things, so I personally am not doing anything with it. We see the cases. There's, with June syndrome, there's a bunch of things that people are trying, including things that we're trying. But that's nothing that's active right now. If you would like to collaborate on a June syndrome type case, it'd be great to go and have like a big multidisciplinary meeting with the pulmonologists and ped surgeons and some of the 3D printing work that's done to work on those really complicated kids.
Well, thank you. Thanks so much for teaching us today. It's amazing all the innovations. Thanks for all the collaborations with our hospital too, and teaching and preparing and then implanting. It was just great work. Thanks again.
Yeah.